Good morning to all. I would like to thank the opportunity to be here with you, sharing some data or some recommendations of specialists regarding endotracheal suctioning in 2013. What do you really know? I tried to stop in 2013. You have some three or four articles go ahead of it. I have no conflicts to disclosure. What we do really know, we really know that air management is a crucial element in providing life support to critically ill children, as Professor Curley and Patricia Maloney-Harmo has been teaching nursing from around the globe with the yearbook. We really know that advanced airway management includes the placement of an endotracheal tube to enable mechanical ventilation. And the endotracheal tube eliminates the normal protection against aspiration so that secretions from the oropharynx can be aspirated, and maintaining the endotracheal tube patency is critical for children and neonates receiving mechanical ventilation. So endotracheal suctioning has the primary purpose of remove secretions, prevent airway obstructions, prevent atelectasias, optimizing oxygenation and ventilation, and decreasing the work of breathing. The endotracheal suctioning is performed mainly by nursing and physiotherapists staff, and nursing and physiotherapists staff has a wide variation across the globe according to the practice scope and the education level. So what do you really know? That the adequate humidity is very important when we are talking about patency of the endotracheal tube. Maintain it at 100%, gas warm it to 32 to 34 Celsius degrees, keeps the secretions loose, lubricates the endotracheal tube, and protects the surrounding trachea tissue from the infiltration. So the endotracheal suction is one of the most common procedures performed in pediatric intensive care units. For Andrew Argent, the ideal endotracheal suction would be pain-free, discomfort-free, safe, with no adverse events like loss of lung volume, desaturation, alterations cardiovascular or in the central nervous system, without damage to respiratory system or infections, and effective, removing secretions and preventing the obstruction of the endotracheal tube. But Evans and colleagues from Australia has been demonstrating that endotracheal suctioning has a specific significance and risk in pediatric neonatal patients. The smaller diameter of the endotracheal tube increases the risk of blockage and many serious complications and risks, including hypoxemia, atelectasia, bronchoconstrictions or spasms, cardiovascular instability, infections, pain, and elevated intracranial pressures can be identified. In this research conducted by Professor Mero and colleagues in South Africa, as you can see, the dynamic compliance and the mechanical inspirated tidal volume decreased during suctioning. And we have studied, published in Portuguese, and accomplished in my university in 13 children, demonstrated the same effects in the tracheal suctioning, decreasing the oxygenation and decreasing the lung compliance. So what do you really know? We really know that we must prepare the patient because this is an uncomfortable procedure described by adults and for older children. So as endotracheal suctioning is frequently performed and causes pain and discomfort, at the procedure is often performed in all ventilated children must receive analgesia previous to the procedure. So to reduce harm and increase the quality of the endotracheal suctioning, some questions arise about what do we really know, about how often the frequency of endotracheal suctioning, the use of pre-oxygenation, forehanded procedure, use of closed or open systems, deep or shallow suctioning, or installation of saline solution. So I will try to describe and share some ideas about these questions. How often? For the American Association of Respiratory Care, endotracheal suctioning should not be performed as a routine intervention, but rather as clinically indicated. In this comprehensive review of the literature published in the Pediatric Critical Care Medicine by Professor Merrill and Professor Andrew Argent. There are no randomized controlled trials regarding this subject, but observational studies of clinical practice have suggested that the identification of the need for endotracheal suctioning is a complex issue involving changes in both clinical sites and patient behavior. These colleagues from Australia tried to understand what lead the nursing's decisions to suctioning the patients. So they surveyed nurses from the Australian and New Zealand Association of Critical Care Nurses, and they identified that the main clinical criteria in determining whether to perform endotracheal suction for these nurses were the suspected of obstruction of the endotracheal tube, the visible or audible secretions, decreased oxygenation, saturation, and cyanosis, and suspected aspirations was the main clinical signs that lead a nurse to do endotracheal suctioning. These colleagues with this data tried to develop a tool, an endotracheal suctioning assessment tool, considering clinical criteria, assess the respiratory status, and also the ventilator status. This was not validated. I cannot find the validation. They said that they will clinically validate it, but this is a very good tool that can help junior nurses to decide when to do suctioning. The frequency is very important when we are talking about specific patients, like, for example, in traumatic brain injury patients. In this literature review conducted by Professor Livon Toon and Anna Jenkins from UK, they analyzed that all studies demonstrated that endotracheal suctioning produced a statistically significant elevation in intracranial pressure. They identified in 2 studies concluded that COTCH during endotracheal suctioning increased the intracranial cerebral pressure. And the avoidance of deep suctioning can be important in these patients. Most studies reported both reductions or increases in cerebral perfusion pressure, so we do not have conclusions about it because of the other clinical variables. Respiratory physiotherapists and mainly endotracheal suctioning is significantly raised intracranial pressure. Hyperventilation previously to endotracheal suctioning and intracranial pressure, there has different results in different studies. And any significant findings when we are talking about nursing care and control of manipulation with these patients. There is some evidence that certain drugs can minimize intracranial pressure rising during endotracheal suctioning. So what is clear for this author is that evidence overall remains inconclusive in this field, as there are contradictory results in many studies. Regarding pre-oxygenation, the Cochrane database tried to do a meta-analysis about this subject, but they were able only to include one study for 1987, and so this review does not provide sufficient data, despite this fact that this study randomized trial crossover with neonates demonstrated that an increase in 10% of oxygenation previously to endotracheal suctioning has a positive effect. For the American Association of Respiratory Care, in preparation for the suctioning event, delivery of 100% of oxygen in pediatric and adult patients and a 10% increase of baseline in neonates for 36 or 60 seconds prior to suctioning can be a good option. For Brenda Morrow and Andrew Argent, there is only one randomized trial about the subject in pediatric patients, and so the fall in saturation and oxygenation occurring as a result of suctioning was completely prevented by delivering 100% expired O2 for 1 minute before the procedure. Considering the short-term effects of hyperoxygenation in reducing hypoxia, patients should receive increased inspired oxygen levels for brief periods of 60 seconds before suctioning. The optimal level of pre-oxygenation is not unknown, and the clinical context should be taken into consideration. So this is a recommendation based in just one trial. The forehand procedures is something that we use very much in clinical practice in unstable patients. When we are using mainly open system to do endotracheal suctioning. There was a very nice research conducted in US, Professor Mary Jo Grapp, analyzing in neonates the use of this technique. So the objective of this clinical trial was to compare the effect of forehanded care on preterm infants' physiological response, like oxygenation, heart rate, and stress, and behavioral response, like state, stress, defense behaviors, and self-regulatory behaviors, versus routine endotracheal suctioning performed by a sole caregiver. This is a crossover study with 10 infants less than 37 weeks gestation at birth, less than 1 week old, intubated on conventional ventilation and receiving inline suctioning were recruited with parental informed consent. What they found was that the use of forehand procedures has no effect in heart rate, but has a significant effect in oxygenation saturation. Although also stress response, they measured cortisol. The salivary cortisol was measured and did not differ between groups, but stress and defense behavior had significant effects. More stress and defense behaviors were seen during routine care than forehanded care in the post-suctioning period. So it's a very nice research, and I think that in pediatric critical care, it can be an important thing to analyze. Regarding the use of closed and open system, we have a lot of research conducted in this practice. In countries like Brazil, when they have low resources, we usually use open systems. It's very difficult to use closed because it's for us, it's more cost. So we have to analyze which patients can use this kind of support. So regarding it, to the American Association of Respiratory Care, the closed suctioning technique facilitates continuous mechanical ventilation and oxygenation during endotracheal suctioning, and protect the caregiver from the secretions and occupational hazards also. In this review of literature in pediatric patients, although there may be short-term benefits of closed system in terms of reduced volume loss and hypoxia, there is no clear benefit for Professor Morrow and for Professor Argent. This study conducted by Bev Copnell that have been studying for a long time this issue, they identified that closed endotracheal suctioning interferes with ventilator function in volume target model, with substantially negative intratracheal pressure during suctioning, and the potential of high airway pressure and tidal volumes following up the procedure. These effects should be considered, and the pressure limits set appropriately whenever using volume-controlled ventilation. So this is an open problem. We conducted with a student, a master in nursing student, a crossover randomized controlled trial on endotracheal suctioning with open and closed system, analyzing pain and clinical parameters in newborns. This study, we compare respiratory rate, blood pressure, oxygenation, heart rate, and pain using the premature infant pain profile scale, were analyzed immediately before the procedure, during the procedure, immediately after, 10 minutes after, and 30 minutes after. And in this trial, we were not able to find any significant difference between groups, despite the fact that newborns has less pain and less changes in respiratory rate. These alterations and this short sample of children cannot demonstrate any difference between these two techniques. For these Australian colleagues, Evans and colleagues from Melbourne, they analyzed in an audit period using closed and open systems in a PICU. In each month of the audit, it was alternatively designed as an open or closed month. Both methods of endotracheal suctioning were practices in the unit, so everybody knows what to do, what's not a new technique. All patients with an endotracheal tube were included in the study. They studied 229 patients, more than 6,000 endotracheal suctioning episodes. They were able to identify that the use of closed system increased the number of suctioning episodes. The use of a closed system reduced the use of saline lavage between in the procedure, and the closed system there's no significant effects in adverse events occurrence. What they really found is that the use of closed system decreased the number of staff in a single staff or the overall staff, and also that the use of the closed system reduced significantly the saturation decrease, alterations in mean arterial pressure, and alterations in heart rate. So, for these colleagues, it would be nice to use closed systems because of staff-related improvements, and some physiological alterations were prevented. Regarding deep and shallow endotracheal suctioning, we have one randomized controlled trial conducted in neonates. So in pediatric patients, we do not have many evidences. This is the randomized controlled trial that Cochrane tried to do again a systematic review, but only this study could be analyzed, and there is no evidence regarding it. Regarding installation of saline solutions, there are a lot of evidence that we must not do this. And I think that this is the non-evidence-based procedure most performed in pediatric intensive care unit around the globe. The more we have evidence, no recommendations to do this, we continue to use this practice around the world. We have a very good design, a randomized controlled trial in children, demonstrated that the installation of saline solutions, there's no benefit effects in improving the suctioning, and it has adverse events to the patients. To the American Association of Respiratory Care, this could not be used as a routine practice because we produce excessive caution, decrease oxygenation saturation, produce bronchospasms, dislodgement of bacterial film that colonize the endotracheal tube to lower airway areas. We cause pain, anxiety, dyspnea, tachycardia, increased intracranial pressure, and unfortunately, as we can see in this study that 2014 from Australia, we can see that in open system, 40% of the episodes of suctioning had saline solution installation, and when using the open system. In closed system, 18%. So overall, 30% of the suctioning episodes, the nurses use saline solution until now. So we have to analyze it. Other considerations that we not have clear data regarding, for example, the catheter size we must use. There are no strong evidence, just recommendations that it should not exceed 1/2 of the inner diameter of the endotracheal tube. And Professor Morrow and colleagues in this article in the Intensive Care Medicine for 2004 provide us a table that can help to decide what type of catheter to use. According to suctioning negative pressure, it is also inconclusive. It must be the lowest possible. For some Morrow and adjunct in experimental research, 360 milligrams of mercury. For the American Association of Critical Care in neonates, 80 to 100, and to pediatric patients, 150 millimeters of mercury. According to the duration of the suctioning, it's also inconclusive. It must be the lowest possible. For the American Association of Respiratory Care, 15 seconds. For Morrow and Argent, less than 10 seconds. And we must have in protocols of less than 5 seconds. So what we do, we really know that there is a lack of strong evidence. Few randomized controlled trial in children, most evidence is from newborns and adults, no systematic review with pediatric critically ill children, even some important evidence we have, like for example, saline solution installations, we do not have an important change in practice. So endotracheal suctioning is one of the most common procedures performed in the PICU, with evidence lacking to support daily practice. Thank you very much.